Good morning, ladies and gentlemen. So today is part two of the topic which I started last week, and that is the principles of phototherapy. I am Professor Dr. Asher Ahmed Mashood, and you can follow me on Instagram, email, and WhatsApp. So today we are going to discuss mainly the adverse effects from the different phototherapy. So first of all, the adverse effects from UVB therapy. And these effects can be divided into acute effects and the chronic effects. So among the acute effects, the most prominent and most significant acute effects are the erythema and burning. Erythema from UVB therapy peaks at about 12 to 24 hours and can be associated with pain, a little bit of swelling, and even blistering. Then burning is most likely to be a presenting feature in patients with type skin 1 and 2, and those in obese, in which greater area of the skin is treated by the therapy, or those who have inadvertent previous exposure to sunlight. Burning may also be due to operator error in programming the cabinet or selecting incorrect or high dose for a particular patient. As far as the mild erythema and burning is concerned, it is easily managed with topical corticosteroid creams and emollients, while more severe reactions require a short course of oral corticosteroids or NSAIDs. Another common acute effect is induction of pruritus, which is either due to the phototherapy-induced dryness or to the underlying disorder being treated. It is usually controlled by emollients. Then some patients may notice reactivation of herpes simplex virus, commonly around the lips, especially those with a history of frequent attacks. Then lesions may blister. I mentioned it before. The lesions may blister, for example, in psoriatic plaques, which is uncommon side effect with UVB therapy. This is usually asymptomatic and settles spontaneously following some dose reduction. If a large blister develops, that you can puncture it with a sterile needle and apply a little dressing for 24 hours. This blistering can develop in absence of erythema and burning. Then some patient might notice a flare of polymorphic light eruption, which is again an uncommon occurrence and is managed by topical steroids and adjustment of the treatment regimen. Now, the chronic effects of UVB phototherapy. The first is the photoaging that may be induced or exacerbated by this therapy. Skin develop a leathery appearance with xerosis, wrinkling, pigmentary changes, loss of elasticity, and increased fragility. Carcinogenesis. Broadband UVB has an estimated risk of non-melanoma skin cancer of about 2% per year. This risk is not well defined due to many confounding variables like a recreational sun exposure, exposure to the sunbeds, skin type, and exposure to systemic immunosuppressive therapies. The genital protection, however, is very important, and it is continued to be recommended to minimize the risk of genital SCC. Now, the adverse effects related to PUVA therapy. Acute effects. First and foremost is the acute phototoxicity. The erythema induced by PUVA is delayed. Mentioned before that UVB-induced erythema develops in 12 to 24 hours. However, the UV PUVA-induced erythema develops in 2 to 3 days. And thus, and there is an incurring risk of cumulative injury if treatment are more frequent than twice per week. For example, if you have placed the patient on thrice a week treatment, which is of course not advisable as far as the PUVA is concerned. So the erythema, which usually develops after 2 to 3 days, before this erythema, you induce the patient again to another session of PUVA, and as a result, the erythema which will develop will be of much more severity and intensity. That is the reason why PUVA therapy is always advised to be twice a week rather than thrice a week, which we usually advise for UVB therapy. Acute PUVA phototoxicity can range from mild erythema to severe pain and edema, blistering with systemic upsets that include malaise and fever. The PUVA erythema not only appears later than UVB erythema, but it lasts longer as well. Nails are rarely affected by PUVA, leading to photoonycholysis and subungual hemorrhages. Episodes of burning are more common with topical PUVA than with oral PUVA. The smaller risk of burning from oral PUVA can be lessened by using 5-methoxysorolin rather than 8-methoxysorolin. Then the management of phototoxic reactions depends on their severity and can range from dose adjustments to withdrawal of treatment. Mild or moderate erythema is managed with moderate to potent topical corticosteroids, cream, and emollients, while severe reaction with blistering may require a short course of oral corticosteroids. Then blistering is reported to be induced by PUVA. Phototoxic reaction to PUVA result in bully that occur most commonly acrally on hands and feet. Provocation of photodermatosis, polymorphic light eruption, and undiagnosed lupus erythematosus is also possible. Then, like UVB, herpes simplex can be reactivated, and management is similar to the management of herpes simplex elsewhere. The less commonly observed side effects include transient nail pigmentation, a facial dermatitis resembling seborrheic dermatitis, folliculitis on the treated areas, facial hypertrichosis, disseminated superficial actinic porokeratosis, lichenoid eruption like actinic lichen planus, headaches, insomnia, and allergic reactions to 8-methoxysorolin. Pruritus occur in 25% of patients, is associated with dryness of the skin and is controlled by emollients. PUVA pain is a rare but a typical and idiosyncratic side effect of PUVA that can last for weeks or months, but does not appear to correlate with PUVA phototoxicity. Low-frequency electrotherapy, topical capsaicin, oral gabapentin, or phenytoin have all been advocated as a treatment. The continuation of PUVA is contraindicated as recurrence of pain is common. Then nausea is a common side effect of patients treated with 8-methoxysorolin PUVA. It can be lessened by taking sorolin with a light meal or by using some antiemetics. Alternatively, patients may be switched over to topical PUVA. The chronic effects of PUVA. Photoaging. PUVA induces photoaging more than UVB, and these changes are not only confined to sun-exposed sites. The pigmentary changes in xerosis are more prominent. These changes are cumulative and dose-dependent. PUVA keratosis is another typical side effect and manifests as multiple hyperkeratotic papules most commonly located on non-sun exposed sites, for example, leg trunk and side of hands, feet, and digits. They occur most frequently in patients exposed to high cumulative doses and are associated with increased risk of non-melanoma skin cancers. PUVA lentigens. These are also very typical lesions. They are large, irregular, stellate, darkly pigmented macules that histopathologically consist of large and atypical melanocytes. Occur most frequently in patients with skin type 1 and 2 who have received high number of PUVA treatments. There is no proven link between the PUVA lentigens and development of melanoma. Interestingly, a recent study has found that BRAF mutation is commonly found in PUVA lentigens, suggesting a pre-malignant potential. Then non-melanoma skin cancers. There is now a substantial evidence for carcinogenic risk of PUVA. There is marked and dose-dependent increased risk of squamous cell carcinoma in an ear and is strongly associated with total number of PUVA treatment round about 350 to 450 and is much less if the number of treatment is less than 50. There is a 16-fold increased incidence of genital squamous cell carcinoma observed in male whose exposure to PUVA is high, that is more than 240 treatments. It is recommended that the lifetime exposure should be limited to 150 to 200 treatments only, with a cumulative dose of 1000 to 1500 joules per centimeter square, and maintenance therapy for PUVA is not indicated. The important risk factors for PUVA-induced skin cancers. Number 1, skin type 1 or 2. Number 2, previous history of skin cancers. Number 3, previous exposure to radiotherapy or arsenic. Number 4, immunosuppressive therapy, especially cyclosporin. Number 5, UVB therapy as well. And number 6, presence of PUVA-induced keratosis or lentigens. PUVA is mutagenic, immunosuppressive, and carcinogenic. Why we say that? P53 mutations are detected in 65% of PUVA-induced SCCs. Then PUVA has various effects on immune system, including decrease in number of CD3 cells, CD4 cells, CD8 T lymphocytes, and both in epidermis and dermis, and also affecting the Langerhans cell immune expression. In addition, PUVA is reported to decrease immune surveillance, which contribute to the carcinogenic effect, especially the lymphoproliferative neoplasms. Melanoma risk. There is a 5-fold increase over the expected incidence of melanoma 15 years after the first treatment. Melanomas were more common in patients with skin type 1 and 2 and those who have received more than 250 PUVA treatments. Ophthalmological effects. PUVA can penetrate the ocular lens, where 8-methoxysorolin has been detected in humans after 12 hours. The cataract development following PUVA is reported. There is also chances of decreased lacrimation and conjunctival hyperemia in some cases. It's recommended that protective eyewear may be worn for 12 hours after ingestion of sorolin and for 24 hours in individuals with pre-existing cataract who may be increased risk of, or those who have an increased risk of cataract like children and patients with atopic eczema. Then the adverse effects due to UVA1 phototherapy. Acute effects. UVA1 is generally well tolerated. Expected acute adverse effects include erythema, pigmentation, induction of polymorphic light eruption, and recrudescence of the herpes simplex viral infection. Then erythema induced by UVA1 has a biphasic time course with a peak at 15 to 60 minutes and a delayed peak at about 8 hours after exposure. So the erythema is quick to develop in UVA1 therapy. The chronic effects. UVA1 phototherapy is photogenotoxic, photomutagenic, and carcinogenic in mouse models. There is, however, no evidence as yet of increased risk of skin cancers in humans. The adverse effects due to extracorporeal photochemotherapy. Adverse effects occurring with ECP are uncommon, providing psoralen is added to the treatment bag and not given orally. The side effects which we expect from ECP include transient hypotension, low-grade pyrexia, increased erythema of skin, and anemia in long-term use. Then patient selection, assessment, and education for phototherapy. The clinic should document the patient's risk factor profile and should include the documentation of skin type, previous natural sunlight, UVB, PUVA sunbed use, previous skin cancers or precursors, previous systemic immunosuppressive drug therapy, and previous exposure to radiotherapy. All of these should be documented. In addition, a full skin examination should be performed to assess the solar damage and to look for presence of multiple freckles, mole, pre-malignant lesions, or skin cancers. So not only documentation, but a thorough examination is must. Then topical and oral photosensitizers should be avoided or lowered initial doses should be used. What are these oral photosensitizing medications? You should remember all of them, and these should be avoided if the patient is placed on phototherapy. So these chemicals include thiazide diuretics, antibiotics, especially tetracycline, quinolones, and sulfonamides, NSAIDs, phenothiazines, retinoids, glycofulvin, sulfonylureas, quinine, and nildexic acid. Topical therapies should also be assessed, and calcineurin inhibitors such as tacrolimus should be discontinued. Then patient with epilepsy should be asked whether seizures are induced by light exposure. If such is the case, then such patient is not indicated to undergo a phototherapy. PUVA therapy is mutagenic and treatment should be avoided in pregnancy. We can go for UVB therapy in pregnancy. Oral PUVA should be used with caution in patients with significant liver dysfunctions. Then patient and staff safety. Individuals who may be exposed to UV radiation include the nurses and nursing assistants, medical physicists, doctors, and physiotherapists. The most important risk to staff is an inadvertent exposure to UVB. Staff who conduct dosimetry should wear goggles, face shields, appropriate clothing, and sunscreens if they have to enter the cabinet with lamps on. When UV cabinets are being used, lamps should be switched off before opening and entering the cabinet. Then these are important guidelines in case of mistreatment for erythema. If a patient has developed erythema and you have to postpone the treatment, then the guidelines are as follows. If the treatment is avoided for less than 7 days, then you can start the patient with the last dose of UVB therapy or PUVA therapy. If the phototherapy is stopped for 8 to 10 days, then repeat the last dose. Then if the time lag is 11 to 15 days, then reduce the last dose given by 20%. And if this reduction is below the starting dose, then restart the patient with the starting dose. If the loss of treatment is for 16 to 20 days, then reduce the last dose by 35%. And again, if this reduction is below the starting dose, then make a new start. If the loss of treatment is more than 21 days, then the dose should be between 50% of the last dose and the starting dose, depending upon the skin type and the treatment modality used. Patient follow-up and skin cancer surveillance. It is recommended that patient who has exceeded 1000 to 1500 joules per centimeter square or 150 to 200 exposures of PUVA should have an annual skin examination carried out to detect any pre-malignant or malignant skin lesion. It's particularly important in patients with other risk factors, particularly of skin type 1 and 2. The preliminary data on narrowband UVB have not, however, suggested a significant increase in skin cancer risk, and further long-term data is required. It is recommended to limit lifetime exposure to 450 treatments. However, there are concerns about defining a ceiling number of treatments in absence of robust clinical data to support this, which is, of course, lacking. Then the new developments. Phototherapy is a highly effective and safe treatment option for many skin diseases, and continued awareness of the availability of this form of treatment is important. One of the factors limiting further therapeutic advances in phototherapy sources have been our relative lack of understanding of the action spectra of clearance of the disease other than psoriasis. So the work on other skin conditions being treated with phototherapy is much less as compared to that on psoriasis. Advances in technologies are enabling the development of compact, portable, efficient, and inexpensive UVB and visible light emitting diode, LED light sources. Then the last topic of today's lecture is Eximer 308 nanometer laser light therapy. Eximer 308 nanometer light is a form of targeted phototherapy that delivers a specific wavelength of 308 nanometer of UVB radiation using an excimer laser or excimer lamp. Both have shown similar results regarding the efficacy, but have some technical differences. The UV ray generated by excimer light is delivered via handheld wand that focuses on the lesion. It is shown in the picture. Comparison of narrowband UVB with the excimer laser. Healthy skin surrounding the affected area is not exposed to radiation. Different templates are used according to area to be treated. A higher dose of radiation can be delivered with a reduced cumulative dose of irradiation. In some cases, a shorter course of treatment is effective. It can be used in areas difficult to reach with conventional phototherapy, such as ear and genitals. It can be used in children and is a relatively friendly-looking piece of equipment. Use of excimer laser therapy. It's an option for treatment of localized vitiligo, moderately severe localized psoriasis, and unresponsive to topical treatments. Some case report documents its use for localized severe atopic eczema, alopecia areata, cutaneous T-cell lymphoma, localized scleroderma, and granuloma annulare. Aim of treatment is to deliver a dose that induces visible redness in psoriatic lesions, that is supraerythema dose, but that does not induce blister or second-degree burn. The adverse effects are much less and well tolerated, and the effects include painful erythema, hyperpigmentation, some erosions, cauterization due to trauma, reactivation of herpes, and it is less risky than narrowband UVB, and it doesn't expose the whole body to UV radiation, so the chances of carcinogenesis is almost negligible. The treatment protocol. There is no widely accepted disease-specific protocols. Patient attends clinic 1 to 3 times a week. The amount of UV delivered is carefully calculated, taking account of the skin type, age, skin condition, site, and response to the treatment. The duration of treatment is shorter than for the whole body phototherapy. Some response may be noted as early as 6 to 8 treatments, and complete response take 20 to 30 sessions. Average length of treatment is about 7 weeks. Some patients have long remission periods while others relapse within 3 to 6 months. So this brings to end of this lecture on the protocols of phototherapy. So join me next time with another topic of discussion, and most probably this will be the principles of systemic therapy. Thank you very much and have a very good day.